Hi, good afternoon. My name's Kelly. I'd like to welcome you to our virtual webinar session on Echo in the COVID era. This session will be delivered based on collaboration between the Royal Society of Medicine and also the British Society of Echocardiography. I'd like to say a big thank you to GE, who are our sponsors for today's session. And also a thank you to Richard Fisher, who will be my co-chair today. I'd like to start by saying the last few months have been unprecedented. We as healthcare professionals have seen huge change. Our experience with COVID-19 has been multi-layered. So we're working with patients with COVID. We have family members affected by COVID, and some of us have contracted COVID. The program for today will focus on introducing COVID and its cardiovascular consequences. We're going to talk about the role of echo and also the role of lung ultrasound. We're also going to look at echo service planning, both in the response phase and in the post-COVID phase. And then we'll look at suggestions about how we can plan for a potential second wave. So far, we have seen a very uncertain 2020. We're dealing with lots of problems in which we have very little experience, and that means we have lots of questions. So today's session is aimed at attempting to try and answer some of those questions using the most up-to-date information that we have to hand at the moment. We really want to encourage people to ask questions, so please do this by uploading those questions through the Q&A icon on your screens. You can also upvote, and that means that those questions that are of particular interest to you will be pushed to the top, and you can do that by clicking on the thumbs up symbol. We'll be answering questions as we go along, and also those that are trending as more popular we'll be fielding at the end in the Q&A session. There are BSc points available for this session, so you'll receive these if you complete the survey, and you will receive the survey link on exiting this session today, but also you'll get the link in a Zoom email in the next few days. Hopefully you're all familiar with the location of the exits and the loos. We aren't expecting any fire alarms today. We are hoping for no technical glitches, but if this does occur, please bear with us. Many of us are new to this. So without any further ado, I want to introduce the first speaker, who's also my co-chair, Dr. Richard Fisher. Richard is a consultant in general critical care practicing at King's College Hospital. He's undertaken a CCT fellowship in perioperative and also critical care echo, and he did that at the Brompton. He's also founded the Foundations of Echo course, as well as being a founding member of the South London Intensive Care Echo Group, and he's taught TOE on dozens of courses around the country. He's a member of the BSc Educational Committee and also the Level 1 subcommittee. Today, he's going to be introducing the concept of COVID.
Thank you, Kelly. Okay. So I'm just going to put my presentation up, guys. Okay, so I've been asked to introduce this topic to everybody. I suspect it probably doesn't need much in the way of an introduction. I'm sure that people have read and heard little else in the last 3 months. I'm going to talk a little bit about what we know about the pathophysiology of COVID-19. Exactly as Kelly says, what we know about the pathophysiology is going to change over time as more evidence becomes available. And I'm going to take you into the intensive care unit and show you some of the extreme disease phenotypes that we've seen in some of the sickest patients. Here are my conflicts of interest. Okay, so to start off with, COVID-19 disease is caused by the SARS coronavirus 2. It's so named because it's genetically very similar to the SARS coronavirus that caused the SARS outbreak in 2002-2003. And so a lot of what we know about how this organism causes disease in humans comes from what we learned from that pandemic or other epidemic. So the SARS virus binds to the ACE2 receptor in human cells, and this is expressed on many different tissues, including the lung and the respiratory tract. Now, ACE2 is a part of the renin-angiotensin-aldosterone system, and what it normally does is it breaks down angiotensin 2, which is obviously a potent vasoconstrictor. And so one of the possible pathological mechanisms of this virus is that it downregulates the ACE2 receptor, and therefore you have more angiotensin 2 available, and therefore you may get local vasoconstriction. That's one possible pathogenic mechanism. When it binds to the ACE2 receptor, it's then going to be taken into the cell and take over the cell's sort of cellular reproduction, and it's going to produce more viruses. And so it will then have a toxic effect on the cell by destroying the cell as it takes it over. So a sensible next question, if we know that the virus uses ACE2 to get into the body, where do we find ACE2 in humans? So it's expressed on lots of different tissues. This is some work done after the original outbreak in 2002-2003. And so you can see here we've got some tissue from a healthy patient. This is lung tissue. And this is an alveolus that I'm outlining now with the mouse. And you can see just in this small area here, this is an alveolar capillary. And they stained this to look for ACE2 as expressed on the surface of the receptor, the surface of the cells, and you can see it's in both the alveolar capillaries and on the alveolar cells themselves. Beyond the lungs, it's also found in the heart, kidney, vascular smooth muscle, and the GI tract, as well as many other tissues. And this may be partly to explain why it's such a multi-systems disease. This is from a patient who had SARS. This is from a patient who died in Taiwan, a post-mortem specimen, and this is obviously an electron microscopy. This is a pneumocyte from the lungs, and you can see here baryons within the pneumocyte on different magnifications. So who's getting this disease? Well, obviously it's a disease that affects basically sort of children and adults, but predominantly adults. And how does it present to hospital? So this is a paper that's come out of New York. They looked at 5,700 patients who they admitted to their hospitals, and they looked at what they looked like when they were admitted. And these were patients who were frequently febrile, they had raised temperatures, they had hypoxia, so many of them required supplemental oxygen, and they were tachypneic and tachycardic. But at presentation, not many of them required ITU. And this is very similar to the pattern that we're seeing in the UK, and certainly we're seeing at King's. So what we're saying is that some of these patients are presenting late and require admission to intensive care straight from the emergency department, but actually that's the minority. And the majority go to the medical ward where they're treated with supplemental oxygen, which may be under pressure in the form of CPAP or high flow nasal cannula, before deteriorating over hours to days and ending up in ITU. This is a series, again, from China, looking at chest CTs done at different stages of the illness. So each of these patients has had their CT a number of days after their first onset of symptoms. So you can see here, this 56-year-old gentleman, this CT is done at day 3 post-onset of symptoms. And you can see just a small area of ground glass opacification. This patient is a week into their illness now, and you can see that this has spread to affect both lungs. There's multiple patches throughout both lungs, predominantly peripherally, but occurring elsewhere as well. And you can see that as this then progresses, so we're now into the 3rd week of illness in these 2 patients, and they're starting to develop complications. They're starting to develop pleural effusions, starting to develop confluent consolidation. This is one of the patients that we looked after at King's. So this is a patient, so a male patient who presented about just after a week after their first symptoms. And you can see even at the time of presentation, they've got diffuse bilateral infiltrates on both sides of the chest. And this patient was initially treated with CPAP. After 4 days of treatment of CPAP, he's now starting to clinically deteriorate. And you can see there's a marked deterioration in the appearances of his chest X-ray. And he gets admitted to ITU where he's intubated. He's now 3 weeks into his ITU admission. So this is a disease that takes a long time to get better. And you can see that he's got patches now of consolidation forming, which are obvious on his chest X-ray, but even more so on his CT that was done over 3 weeks now into his admission. And you can see these patches of consolidation. What you can't see on this image is that he's got areas of cyst formation slightly higher up in the left lung. So maybe he's got secondary bacterial infection. What you also can't see on this is that he's got PEs as well. So PEs is something that we're seeing in a lot of our patients. We're doing a lot of CTs now. We didn't start off by doing a lot of CTs because I think we were worried about moving patients with this communicable disease around the hospital, but I think we're getting happier about doing that. And we're starting to see very small and medium-sized PEs within the segmental and subsegmental branches of the pulmonary vasculature. There's a couple of papers that have tried to work out the incidence of this. This first one from the Netherlands quoted an incidence of PE in ITU patients of 14%. What's worth noting, though, is that 76% of their patients were still in hospital. So conceivably, the incidence was going to be a lot higher because there are still patients who may go on to develop this. This paper from Italy found a much lower incidence of PE, just 3%. But I saw a paper in intensive care medicine this morning, I'm afraid I've not been able to put it up onto the slide, that had a quoted incidence of about 16%. So significant number of these patients are developing PEs. If they're developing PEs, is that because they're hypercoagulable? That's certainly been suggested and postulated. What evidence is there for that? Well, we know that in patients who do worse, they have elevated levels of D-dimer compared to those patients who do slightly better. So these are two papers from China, and you can see here that survivors compared to non-survivors in both of these groups had levels of D-dimer that continue to increase after they were admitted to hospital, and the higher the D-dimer went, the more likely you were to not survive the illness. This disease certainly has phases, or it certainly appears to have phases. So we start off with a viral replication phase, and this is the patients who are at home. They haven't come to hospital yet, and they've got what you might consider to be typical viral symptoms. So they've got myalgia, lethargy, maybe upper respiratory tract symptoms. And then as this starts to sort of become less prominent, they start to get this secondary inflammatory response. And this is probably when they come into hospital around about here, and they probably end up in intensive care somewhere around about the sort of this stage here. And they start to get these inflammatory responses that are initially within the lungs and then elsewhere. And we see this can potentially be bimodal, and in the sickest patients, they have a secondary late hyperinflammation. How do we see this in sort of studies? So we've got a study here which looked at cytokine levels in these patients. Interleukin-6 is a very pro-inflammatory cytokine. We often see this elevated in patients with severe sepsis, and you can see that these patients who don't survive, so the ones in red, have got elevated levels of interleukin-6 compared to survivors at all stages of the disease, but particularly in this third week of the disease, you can see it starts to sharply rise up. Are we seeing that at King's? Yeah, we absolutely are in many of our patients. So these are these are CRPs over time in 4 patients, and you can see that we have this rise from when they first present to very high levels. We've got 500 here, 600, 300, 500 again. And we also see this bimodal distribution frequently, not always, but frequently, where the CRP rises, the patient becomes very inflamed, and then maybe this patient starts to settle down symptom-wise, the CRP starts to fall, and then somewhere between a week and a week and a half later, we get this secondary peak. What are we seeing in the intensive care units? Well, we've had in the UK over 10,000 admissions to our UK ICUs now. This information was about 10 days old, and you can see that the peak of admissions was around about the end of March, beginning of April. It certainly wasn't a disease that hit everywhere equally. So South London, where I work, is the area that's seen the largest number of cases. And you can see that London dominates, with South and then the 2 North London areas having the most cases so far. But also there's been a large number of cases in the Midlands. What do these patients look like? So they are predominantly elderly or middle-aged. So the median age of patients coming into the ITU has been 60. We're seeing more men than women, so about 70% of all patients admitted to ITU in the UK have been men. Black and minority ethnic groups have been overrepresented, so we're seeing more Black and Asian patients than one might imagine based on that population. And again, obesity is overrepresented as well, and many of these patients got elevated BMIs. This is a really serious disease, very, very highly fatal disease, certainly if you end up in intensive care. So of all the patients admitted to intensive care who have left intensive care, roughly 50% have died and 50% have been discharged from ITU alive. And if you're mechanically ventilated, then the mortality is probably going to be worse than 50%. So this graph here shows you patients who have survived the illness in the dotted line, patients who've succumbed to the illness in the solid line, and you can see that we're looking at maybe somewhere around about 40% survival if you're mechanically ventilated. Also, to hit home the fact that this is a long disease, takes a long time to get better, at day 30, 1 in 8 patients admitted to ITU and mechanically ventilated was still in intensive care. So it's not something that you get better from quickly either. Okay, so in summary, COVID-19 is not just a disease of the lungs, it's a multi-system disease. There are a number of reasons why that might be the case. Certainly the lungs do seem to be the most hard hit part of the body, certainly initially, and this sort of severe hypoxic respiratory failure is the main phenotype that we're seeing. It's mostly affecting elderly men. It's overrepresented in patients from minority ethnic groups with raised BMI, with a background of hypertension or diabetes. And it's a lethal disease, and it's killing something like 50 to 60% of the patients who are admitted to ITU and receiving mechanical ventilation. Okay, so that's all we're going to that's our introduction. I'm going to now hand over to Dr. Bushra Rana, who's a consultant cardiologist and the lead for echocardiography at Imperial College in London. And she's going to tell us a little bit about how we're going to echo service planning and how our departments are going to respond to this crisis.
Okay. Excellent. It's working. I was trying to do it myself, but someone's helped me. Wonderful. Thank you very much, Richard. Thank you very much for a very interesting talk. I'm just going to share my screen and set up my slides. And I've been given the task of just talking through what we have done in the initial stages of the pandemic. In effect, we started this in the middle of March. And obviously I'm part of a huge team at Imperial, which I'm very proud to be part of. And together we've collectively developed this. So this, while it feels like actually we're in the midst of this now and things are moving forwards, actually some of the principles that I wanted to highlight, and this is really what I'm going to focus on in this talk, it is really applicable, I think, throughout the pandemic, which, as we're hearing, could go on for not just months, but maybe a year or two, if we're unlucky. So the principles that underpinned how we set our service up in the setting of the pandemic were 3 key steps. The first was to assess the infection risk, because the immediate issue really was to work out who we scanned, who we didn't. So we needed to clarify the indication for the echo, and then we needed to deliver the appropriate level of imaging. So I'm just going to talk through what I mean by each step. So the first step, assess the infection status of the patient. So essentially we use a traffic light system, and we categorize the patients in terms of whether they had COVID, so confirmed COVID, usually meaning they had a positive swab or significant and reliable chest imaging, chest x-ray, CT scanning that really confirmed this was highly likely to be COVID, or our orange category, which would be category 2, where we suspected COVID. So what that would mean from a practical perspective is you have a patient with symptoms, typically cough, fever, but more importantly, we would also look at their bloods to be sure that this fits in with the background. So things like raised CRP, unusual settings where in fact you had a neutrophil count that was normal, a low lymphocyte count, D-dimers, LDH, ferritin typically being raised. And if you did it, procalcitonin, you typically see was down unless there was some secondary bacterial infection. And along with that, we'd also check chest x-ray CT imaging just to see whether we thought this was suspicious of COVID. So we would rely on the medical team or the team referring the patient for a scan, but we'd obviously want to be clear ourselves before we scan the patient that as a clinical team, we agreed with that this was truly negative or not. So for the negative category, what we mean really there is low suspicion, because I don't think you can ever guarantee that there is no risk, particularly given the limitations of some of our testing. So what that would mean is, this is all in an inpatient setting, essentially, as I've described. So if you take that through to the category 3 patients, who would be those that are low suspicion, you would ensure that the history fitted. You could look at bloods if you wanted to, if you had an inpatient. But what I wanted to point out is for the outpatient setting, there's a little bit more that you need to engage. And first of all, we set up a questionnaire, which in fact we do ask the inpatients too if we're not sure, if they haven't had swabs, as well as looking at their bloods. And I've listed the key questions here. Because of time, I'm sorry I can't go through the detail, but I just wanted to make sure you had that on the slides. And then the second thing we have started doing is actually doing a temperature check, particularly if they're outpatients. So now I'm just going to talk a little bit about the protection, the personal protection equipment. And I think really this hinges on whether we think this is aerosol generating or not. And what I wanted just to highlight is on the WHO website, they talk about how you can get COVID or how you can spread it. And the key words are small droplets that can come from the nose or the mouth, expelled via a patient who's infected through coughs, sneezes, and speaking. I want to highlight that to you. So these patients essentially breathe out these droplets, and if you're within a certain distance, it says 1 meter, I think maybe up to 2 meters is probably more reliable, then you're at risk of potentially catching these droplets with the virus and contracting by inhaling this. Now, in terms of aerosol generating procedures, we know the standard procedures that can call it, typically endotracheal intubation, endoscopy. But what I wanted to highlight from an echo perspective is TOE is considered an AGP. Suctioning, gagging, coughing through the procedure makes it high risk. Exercise testing, which I know that Mikhail will talk about a bit later on, also in our view is aerosol generating, coughing, deep breathing. And I also wanted to highlight that on the wards, be aware that nasal oxygen, high flow oxygen, can cause aerosol generating. I know there's some debate, but in our mind, if there's a debate and if we're not sure, we need to think about this. IV cannulation, clinical examination, interestingly, some papers are showing that that even causes aerosols. So it's important to understand the patient context. So a little bit more about this concept of droplet spread. So we believe that if the droplets are more than 20 micrograms, they are large and they'll drop to the ground. They won't go more than 1 meter or 2 in front of the patient. If you cough or sneeze, they can go further. And this is a video just showing a patient sneezing. And in fact, what I wanted to point out is, as you see from the video, is as they sneeze, there are big droplets, but they are also these micro droplets. And so thinking about that a little further, if I play this video, what it shows is these micro droplets are essentially acting like aerosols. They stay in the air. And as you watch within an area that isn't ventilated, this aerosol spreads over several minutes, as you can see here, to essentially really fill a large room. So this is important from our perspective. And if you use ventilation, which is what they're showing here, you can pretty much remove a lot of this, this aerosol that's generated. So this slide really shows you the difference between the aerosol generating procedures and what the effects of an aerated room look like, and where echo really fits within all of that. So there's a lot to think about here. So that then brings me on nicely onto how we think about our PPE. And again, I haven't got time to go into great detail, but what I wanted to highlight is, remember that echo is it's an intimate exam. We're in close proximity, continuous contact with the patient. It's a face-to-face interaction. We're sharing the same breathing space as the patient. And so our PPE is important. And for us, basic PPE does require full upper body cover. So we are talking about gowns. We're talking about a surgical mask if you think the patient is negative. That's fine, but there is still some risk. So we always cover eyes and wear a visor, and we obviously wear gloves. Full PPE everyone knows about, and really there's no debate. If you're positive or suspected, as far as we're concerned, the type of scan we're doing, the intimate procedure, it requires full PPE. I've got the detail there to show you, but I wanted to highlight that PPE is really important, particularly when you look at the statistics. So if you look at NHS, our NHS staff, about 1/5 of the population of our staff are from the BAME background. There's a nice bit of data that was published here that I referenced down here, but essentially this shows that there's a disproportionate number of BAME staff who are dying, 63%, even though we make up 21% of the population. But what's really interesting is there were no deaths in staff in ICU and the anaesthetic staff. And what's key here, I want to highlight, is actually the level of PPE that's being worn. So I think, having given you that background, it's important to understand your environment, important to understand your potential exposure to the virus load in the environment that you find yourself in, and then understand the level of PPE in that background. And I particularly wanted to highlight that actually the times you infect yourself is when you're doffing. So lots of practice is very important. Okay, so step 2, we need to clarify the indication. Again, time is short, but I've got the detail in the slide so you can look at this later. But what I wanted to really just to show you was that the key is to make sure that we're only scanning patients in the time when you've got a high viral load throughout the the situation, the environment. It's widespread through the community. Really, we want to be clear we're scanning patients that we're going to make an immediate difference on. There's risk to not just to patients who may not be positive, but also to staff. So once we're clear on why we want to do the test and we've got clear indications, we need to have a clear protocol, and I've given what we're using here in a handheld setting. We've gone to a handheld setting. We're triaging all the patients via clinicians to make sure we have a clear mandate for why we're doing that scan. Handheld devices are easy to clean or more reliable in terms of decontamination. There are a number of other protocols to consider, which I've listed here. And I wanted to also emphasize the importance of the reporting as well. Again, I don't have enough time to go into the detail, but I've put all of this onto my slides just so you're aware. So then step 3, forgive me, I can see my slide now. So step 3 really then is delivering the service. So what I wanted to highlight here in terms of inpatients, because we have this traffic light system and we have infected, dirty areas and clean areas, what we've elected to do is keep our echo labs green. So essentially all patients who are low risk or COVID negative are the ones that are only allowed to come down to the labs. There's some key things that we're doing to ensure that we're limiting the scans we're doing and only doing them for correct reasons. And that includes actually patients who have things like endocarditis or risk of endocarditis. And what we're finding is our infective endocarditis MDT is a very good way of screening patients and actually avoiding doing unnecessary scans. The other thing I just wanted to highlight is, of course, remember that the screening of patients, if you're bringing them down to your green area, is key. We're going to the wards and to ICU to perform any patients who are category 2 or 3. I'm sorry, I'm having trouble going to my next slide. So next area then is to consider the TOE. I've already mentioned that it's an AGP generating procedure and requires full PPE. And really we're limiting the types of TOEs we're doing. The only ones we've done so far is on the wards, on ICU, and that really is an intubated situation. And we're reliably told by our anaesthetists and our ICU team that in that setting, what you have is actually, once the patient is intubated, quite a safe environment, and you have less risk of AGP, but of course we're doing that with full PPE setting. And then in terms of the outpatients, again, because time is limited, I just want to give you some highlights. There's a lot more information on my slides unusually, like most of my talks, but I just wanted to make sure you had all of this to look at when you're going through these, again, as these are all recorded, is remember that we talked about TOE. Our view is that exercise testing is also an aerosol generated procedure. So actually we've put a halt on it in the time of the pandemic, but actually we're now looking at moving back to normal services. So there's now a debate as to how we perform this, but I'm going to leave that to other speakers to tell you more about. But really the key here is when you're looking at immediate and urgent care on patients, most of our exercise testing is done really on asymptomatic patients in risk stratification. And so there's not a good reason to go ahead and do this kind of testing in this acute setting, really, because everything we're doing is symptom driven. We're looking for immediate management changes in our imaging. And things like debutemy stress echo, again, we've put a halt to that mainly. Where we've had concern, we have done it. We're worried because it's more of a prolonged procedure, so more risk of viral load, but we're looking at doing more CTCA as a vetting procedure if we need to. And then my last slide, really, I wanted to highlight in terms of the outpatient delivery service. Yes, we have been doing it. It's on an urgent basis. And the key aspect I wanted to highlight to you is actually the screening that we've done. So we've gone to cold sites. We've used the Echo Lab is green within the hospital, but it's not ideal. We happen to be blessed with community sites, so we're using those as our cold sites. And the key here is actually to make sure you screen the patients so that they're only ever low risk or COVID negative, we hope. And that means ringing the patient up, going through the checklist. When they arrive, going through the checklist again, giving the patient a mask, doing a temperature check, making sure that we're using social distancing measures, patients are spaced out, the list is spaced out, we're only doing 5 slots a day so that we only have a limited number of patients, 1 or 2 at most in the waiting area. So these are the key things we're looking to think about. So back to my summary then, just to say that actually in the acute setting, we've taken the 3-step approach, as you've seen, and I hope that this is giving you some background and information, and I'll stop there. Thank you. Okay, so I hope that was useful, and I'm now going to move on to our next speaker. And our next talk is the cardiovascular consequences of COVID. And I know that between Kelly and Richard's going first, they're also going to talk about identifying the cardiovascular effects by echo, and they're going to kind of share the areas there together. So Richard, I'm pleased to, you've already seen Richard give a very good talk, but just in case there was any doubt, I just wanted to get a little bit of background of Richard. So Richard is a consultant in general critical care practicing at King's College, and actually he's got a really impressive track record and experience. He's done a post-CCT fellowship, perioperative and critical care echo at the Royal Brompton Hospital, so we'll have got some very good training. I'm a bit biased obviously because that's within our region, and I know how good that ICU is. In addition, actually, he's founded the Foundations of Echo courses across South London for intensivists, and he actually has teaching and training experience in transesophageal echo as well as transthoracic echo. And I'm pleased to say that he's also contributing to the education committee and also the BSc level 1 subcommittee as well. So thank you, Richard. Looking forward to your talk. Handing over
Thank you, Bushra. Okay. Exactly as Bushra says, we're going to start talking about the cardiovascular consequences now. I'm just going to try and load this up. There we go. Okay, we're going to divide this in half, and I'm going to start us off, and then Kelly's going to do the second half. So why might coronavirus cause impact on the cardiovascular system? So there's a number of sort of possible mechanisms that have been postulated. So first of all, we know that this virus enters cells by attaching to the ACE2 receptor, and we know that the ACE2 receptor can be found expressed on cells within the heart. So maybe there's direct viral effects. Maybe we have cytopathic effects caused by the virus entering and destroying cells, and maybe it can promote a myocarditis, so a sort of inflamed immunoresponse. Maybe it's secondary to a general inflammatory response. So we've seen that we can see elevated levels of cytokines. We're certainly seeing a phenotype of vasoplegic shock in some of our patients, not all, but in some of our patients. And so maybe this is something that we need to recognize and appreciate. Maybe it's due to thrombotic complications. So we talked about the fact that we think we can see in situ thrombosis within the pulmonary vasculature. Is the same thing happening within the heart muscle itself? And if not, is there anything going on within the macrovasculature? So are we seeing increased rates of coronary artery disease? And maybe it's related to the way in which we're treating these patients. So certainly on the intensive care units, these patients will be intubated and ventilated frequently, and so they will be receiving positive pressure ventilation, and that's going to have knock-on effects on both the left and right heart, but particularly on the right heart, which Kelly is going to talk about. So one of the things that we need to think about and look out for is a viral myocarditis. So can SARS-CoV-2 cause a viral myocarditis? Well, there's some evidence that it might be able to, or it may. So this is from China, again, the place which has given us all of our initial early reports. You can see here that they've divided the patients who had the less severe form of disease, who never went to intensive care, apart from those who went to intensive care. And the patients who went to intensive care on presentation in general had higher levels of troponin than those who have the less severe form of disease. But the levels were never very high. They were within the normal range on average, and only a quarter of patients had levels that exceeded the upper limit of the reference range. Maybe what's more important than what you had when you presented is what happens once you've been admitted to hospital. So again, we have another of these graphs which tracks one of our blood biomarkers over time, and you can see that troponin levels between survivors in blue and non-survivors in red start reasonably similar. But then as you enter this third week of illness, in the non-survivors, we're seeing a large rise in their troponin levels. Are we seeing this in our patients in hospital? Yes, sometimes, not always. So this is one of the patients whose CRP trace I showed you earlier. So this is a gentleman who came in here. He was intubated in the emergency department, and for the first 7 days, he became increasingly inflamed, both clinically, and that mirrored the fact that his CRP rose up to over 500. And then he seemed to settle, and over the next week things seemed to improve. His CRP came down and his clinical phenotype improved. And then he seemed to have his second inflammatory stage about 10 days after the first. You can see that here, this is where he starts to clinically deteriorate. He ends up going on a very large doses of vasopressors, on multiple vasoactive drugs. He has an echo done by one of my colleagues, which shows a hyperdynamic left ventricle, only mild RV impairment, no RV dilatation, despite the fact that he's mechanically ventilated. And then within 24 hours, unfortunately, this patient has deteriorated dramatically, and he's now, unfortunately, at a point where he's going to pass away, and we're unable to stop that. And his last echo before he dies shows a poorly contracting heart. His troponin rises just as he's becoming clinically sicker, but it doesn't rise to astronomical levels. 250 was the highest that we recorded in this gentleman. When we were first sort of anticipating this outbreak hitting us, we were still obviously reading everything that you can get your hands on. So these were two sort of reports that came out of northwestern United States, both at the very beginning of March. The first one is a letter to JAMA, and it talks about 21 patients admitted to ITU, and they reported that 1/3 of their patients developed a clinical cardiomyopathy with evidence of reduced ejection fraction on echocardiography. So that was really worrying to us. We were quite scared at that point, but we were going to see maybe 1/3 of patients admitted to ITU developing what appeared to be irreversible cardiomyopathy that would ultimately end in death. We then have this other report that came out, I think, just a few days later, again from the same part of the world. And in this report, there were, again, small numbers, I think about 24 patients in here. And of those patients, 9 of them had an echo. And in contrast, of those 9 patients that they did an echo in this cohort, there was no new cardiac dysfunction identified. We have got some case reports to go on. So we have, this one is from Guido Tavasi in Pavia in northern Italy. And this is a gentleman who had no history of coronary artery disease, had no risk factors for cardiac disease, who presented with confirmed COVID-19 and whose ejection fraction deteriorated in front of him and ended up going onto VA ECMO. And whilst he's on VA ECMO, he has a endomyocardial biopsy performed. And you can see here that from the endomyocardial biopsy, they're able to see sort of coronavirus virions within the heart tissue. This is within the interstitium rather than within the myocytes. What they didn't see on this endomyocardial biopsy was they didn't see any thrombosis within the capillaries, and they didn't see any inflammatory infiltrate that you might see with a myocarditis. A couple of other case reports. This one is from southern France. Again, a 69-year-old gentleman. You will notice on the echo that the LV wall is a bit thick. This is known, this is pre-existing, and this is secondary to his long-standing hypertension. But they managed to get a CMR in this patient, which I think is quite incredible because he was intubated at the time, I believe. And to do an intubated CMR at the best of times is tricky, but certainly when they're worried about this sort of communicable diseases, that must have been a logistical nightmare. And you can see just about maybe on your screens that there's a bright area of late gadolinium enhancement here at the apex. They felt that that was consistent with myocarditis. Again, another patient, this one is a young lady from South Korea, presented with a very reduced ejection fraction, big dilated left ventricle, became unwell, went to their intensive care unit, and you can see that they've got an edematous left ventricular wall that they felt was consistent with myocarditis. What we really need is tissue. We need tissue from endomyocardial biopsies in live patients, and we need it from post-mortem specimens. There's been a delay in getting post-mortem studies published because I think that we have very reasonably had concerns about whether or not performing post-mortems in patients who've died of COVID-19 is putting our pathologists at significant risk. There are a few series that come out. This one is from New Orleans. They looked at 4 hearts, and in those 4 hearts, there were no inflammatory infiltrates in those 4 patients. And these are from, and this is a study, I think, from New York, where they looked at 12 patients who died. They looked at the hearts of those 12 patients, and one of them did have a lymphocytic infiltrate, whereas the other 11 did not. What they did find was that common findings were cardiomegaly, RV dilatation, and then sort of focal areas of necrosis, perhaps due to sort of viral cytopathic effects potentially. So to summarise that, what do we know about viral myocarditis? Well, there have been millions of confirmed cases and only a few reports in the literature. I think that it is plausible that we can get a coronavirus myocarditis, but I think it's the true instance of it is yet to really be understood, and we need a bit more information to be certain about that. In terms of doing echocardiograms in these patients, I think that anyone who's got an elevated troponin or becomes hemodynamically unstable should have a point-of-care ultrasound looking for left ventricular dysfunction. Doesn't necessarily have to be a departmental full sort of level 2 study. A level 1 study may be adequate in these patients. What about coronary artery disease? Well, we said that we think these patients may be prothrombotic, so maybe we would see more STEMIs. So this is looking at cath lab activations in 9 hospitals in the United States. And you can see that March 2020 is when the pandemic really hit in the US, and you can see that the number of cath lab activations for STEMI decreased in that month. So that doesn't necessarily suggest that we're seeing more MIs, but what you are seeing is you're seeing more out-of-hospital cardiac arrests. Now, one possible explanation is we're seeing more cardiac arrests this year than last year due to the fact that we've got people dying of coronavirus. That would make sense. But another possible explanation is that people who would have previously sort of sought medical attention for chest pain, for example, might be delaying seeking medical attention due to concerns about going to hospital where they know that coronavirus is being treated and maybe presenting late. And over the weekend, I was looking after one of our non-COVID ICUs, and we had several patients admitted with out-of-hospital VF cardiac arrest, and certainly one of them, in retrospect, had been having chest pain in the days leading up to their collapse. I'll skip over this very quickly. This is just a paper from New York looking at 18 patients who had ST elevation MI in the context of being COVID positive. Some of them had it ST elevation at presentation, some of it developed it whilst they were being treated in hospital. The short version was that about half of these patients didn't have regional wall motion abnormalities on echocardiogram, or had an angiography that didn't show an obstructing lesion. And so the suggestion there was you maybe get some sort of non-obstructing coronary sort of presentation with ST elevation. So ST elevation may not necessarily mean coronaries that are blocked, but we certainly, I think, have to look in order to exclude it. These are a couple of patients we've seen at King's recently. So both of these were around about the peak of our admissions. This was a gentleman in his late middle age with many risk factors of coronary artery disease. He was known to have a COVID-19, being treated at his local hospital. And 7 days into his management, he started to complain of chest pain, and he had a very clear inferior STEMI on ECG. Was transferred over to us and went straight to the cath lab, where he had angiography that showed that he's got this thrombus here within the right coronary artery, which was nicely opened up on PCI. But you'll also notice that the rest of the vessel has got quite a good caliber without any obvious other atheroma. So this patient, although he did have risk factors, didn't have any other coronary artery disease to see on angiography, and yet had developed this thrombosis. So maybe COVID-19 gives you an increased risk of thrombosis. This is another patient who arrived a few days later. This was a much younger patient with no risk factors for coronary artery disease, who had complained of chest pain for a few hours before collapsing in a VF cardiac arrest with the ambulance there, thankfully. This patient was taken straight to the cath lab, and you can see here, this is the left main stem, and this is the left anterior descending artery, and there's an occlusion here with thrombus very proximally in the left anterior descending, that again nicely opens up, and the rest of the coronaries are plumb normal. And so the thought at this point of doing this angio was, well, again, this may be a patient who's got coronavirus, who's got coronavirus-related increased thrombosis risk. Well, this patient had multiple swabs taken during their hospital stay, all of which were negative, and actually the rest of their symptomology, the rest of their investigations really didn't point to coronavirus being an issue in this patient. So to summarise this, coronary artery disease is really common. We will see lots of coronary artery disease regardless of whether or not COVID-19 is happening or not. The patients who are getting the worst COVID-19 are also the same patients who are at the highest risk of coronary artery disease. And it is plausible, and I think it's probably true, that COVID-19 can increase the risk of both type 1 and type 2 myocardial infarctions. As echocardiographers, what do we need to do? I think that seeing as we know that the treatment of myocardial infarction is so good that we can make such a difference using primary PCI, I think we do need to scan these patients, and I think that the scan needs to be adequate to pick up subtle regional wall motion abnormalities and mechanical complications such as VSD and MR. who's going to perform those scans? Conceivably, it might be that you get your POCUS scan performed by somebody who's able to do a level 1 scan with maybe a few additional images, and it might be that that's adequate as long as you get that then reviewed by somebody with adequate training. So maybe you find a way of image linking your ward or ICU to your echo lab, or maybe you transfer the images with a USB stick. Okay, I'm going to hand over to Kelly, who's the lead clinical scientist at Guy's and St Thomas's Trust, who's going to finish this bit about cardiovascular consequences. Thank you, Kelly.
Thanks very much, Richard. Very interesting, and some really nice examples of occlusions within the coronary arteries that you guys are seeing at King's. I just wanted to highlight, we've got excellent attendance at the session today. We've had up to 717 people attending, so thank you very much for the interest that you've shown on behalf of the RSM and also BSE. Over the next 10 minutes, let me just share my screen. I wanted to focus on level 1 echocardiography, but we're also going to talk about some of the challenges that are associated with imaging in the critical care setting. We'll talk about the RV, possible reasons for dysfunction, and then also look at the important consequence of pericardial effusion, and finish with a little bit of echo in ECMO. So based on the guidance from the BSE, as well as the American and the European echo groups, we're recommending that patients undergo a limited echo assessment. And it needs to be an echo where it's going to make a change in the clinical management of the patient. So BSE level 1 is ideal for this particular cohort of patients, as it assesses the left ventricular size and function, the right ventricular size and function. It identifies gross valvular pathologies. It also looks for the presence or absence of fluid, whether that be pericardial or pleural. And it also helps with assessing the filling status. It's quick, it can be performed at the bedside, unlike some of the other imaging modalities. So performing level 1 protocol also means that there's limited exposure to the operator, which thus means that there could be potentially assisting with limiting the spread of disease more widely. But echo within the COVID population isn't without difficulties, so we need to think about medical therapies, changes in hemodynamics, and also this particular cohort of patients can be quite challenging to scan. So this tends to be a result of lung consolidation, challenges associated with body shapes. We know that we're facing a cohort with increasing BMI, and we're also seeing individuals with lots more arrhythmia, which hinders our interpretation. We've got patients who are on ventilators, some are on ECMO, and more recently we're also experiencing some unusual artifacts. And of course, as most of you would have experienced, patients in unusual prone positions, which can be problematic. So if we can just focus on the last 2 examples there. Here we've got a picture of it's a group in Australia who are demonstrating the ideal position for imaging patients when they're in the prone position, and you can actually get some useful images from the apical window and also from the posterior window in the presence of lung consolidation or pleural effusions. So that can be helpful. In an ideal world, you try and work on good communication with the critical care teams and try and make sure that you scanned the patient when they were unproned. That's not always possible in the emergency setting. More recently, we've also been experiencing some issues with artifact, and this relates to a new device that we're using, which is coincidentally called ECHOS. It's a system which is a delivery system used to dissolve thrombus and also restore blood flow. So essentially it's delivering a lytic drug, and it also uses high frequency, low energy ultrasound. So there are occasions where it can actually hinder the echo assessment. Now, I'm not going to spend a lot of time talking about the left ventricular regional walls, because Richard's already covered this, but we'll focus on right ventricular function, dilatation, the pericardium, and ECMO. So based on the guidance that was published in Echo Research and Practice just in the last year, we know that the best approach to assessing the right ventricle is to look for dilatation of the right ventricle and also the right atrium. Function is best assessed by looking at both radial and also longitudinal function, and you also need to consider global versus regional dysfunction. So we can use colour flow imaging to assess the degree of regurgitation. IV size and collapsibility can also be assessed. So slightly outside of the realms of level 1 scan, and where it might be useful in the setting of a particular clinical question, you can also assess peak TRV max, and that would help you to evaluate pressures. The recommendation, though, is that for all of these images that we obtain the information and then measurements are performed retrospectively, and that's just to limit exposure time. So based on both the current literature and experience, what we tend to be seeing is that the right ventricle is both dilated and dysfunctional, leading to RV failure. And this may be a consequence of acute respiratory distress syndrome due to hypoxic pulmonary vasoconstriction, or potentially too much CO2, or even as a result of the high driving pressures that we're putting the RV under as a result of ventilation. So approximately 20 to 40% of hospitalised patients are developing ARDS, acute respiratory distress syndrome. And according to the literature from China, mortality is actually around 50%. So this is very problematic. In these patients, the echo should really focus on looking at RV size, assessment of right ventricular systolic pressure, and really concentrating on the movement of the interventricular septum, so looking for evidence of D-shaped flattening. Right ventricular failure doesn't only occur as a result of ARDS alone. As Richard touched on, we're seeing lots of pulmonary emboli, both large and segmental. A recent case report just in the last few days in JAC supports this. Essentially what it did was it followed the course of 5 patients who had an acute increase in RV afterload. And this can progress to acute cor pulmonale as a consequence of obstructive shock for these patients. We know that these patients have blood that is more likely to thrombose. And so in these cases, my understanding is we're giving prophylactic anticoagulation. One other consideration in this particular cohort of patients is that we're treating patients who are both obese and elderly, and these individuals may have a higher incidence of PE in any case, aside from the COVID-related illness. Echo for these patients is not dissimilar, so we need to look at RV size and function, but also trying to identify if there's any evidence of McConnell sign, so a more active apex of the right ventricle, or indeed the presence of clot, which may assist with immediate treatment. And yet, PEs and ARDS aren't the only culprits here either. So we've got the acute coronary syndromes, which could be contributing to RV dysfunction. We've also got ventilation. We've got patients who have increased BMI. Some of these patients will have asthma, some may have underlying OSA. So we need to be mindful of all of these components. We also need to think about the filling for these patients, comparing the right ventricle with an underfilled left ventricle, and also the limitation associated with patients. When we have poor image quality and off-axis imaging, we can often make the right ventricle look bigger. So a recent study published in JAC, it's looked at, it's been based on a cohort of patients who are all COVID patients. And essentially what it's found is higher mortality, which has been linked to RV dysfunction. So it's cited that TAPSI and fractional area change are predictive of RV dysfunction. But the most predictive was actually RV strain. The study had some inherent limitations, but it is interesting to know whether this information from China would be transferable to a UK population. They did note that it was on individuals who were normal BMI. And we also just need to be mindful of extending our practice to look at RVS prime in the setting of exposure to the disease. So if we just move on to pericardial effusions, we're also seeing these within the COVID population. The current literature suggests that it's around about 4 to 5%. And some of this might be more of a myopericarditis or a hemorrhagic component. They're ranging anywhere from trivial to greater, so large, significant, and in some instances we are getting some tamponade. Level 1 echo is very helpful in identifying the absence or presence of a pericardial effusion, but in the absence of any flow variability measurements, it can be tricky to identify whether there's hemodynamic compromise. Remember, we're also dealing with a large cohort of patients who are ventilated. So with that in mind, it's important to remember that tamponade is a clinical diagnosis. Just 2 further points in relation to pericardial effusions. In our experience, patients can have no effusion on a baseline scan, and then on repeat scan within a few days, all of a sudden they have a large effusion. So it may be worth having a low threshold to have a second look. And the second point is just that the COVID patients with pericardial effusion are a very high-risk group, and we've found that on occasions they can deteriorate very quickly, so it's worth just escalating once effusion has been identified. Just some final comments on the use of echo in ECMO. I appreciate not all centres will have exposure to ECMO. For the COVID population, we are seeing mostly single organ failure. So we mostly looking at the use of VV ECMO to support the lungs. We've only required a couple of VA, so lung and heart support. VV assessment is very much focused on the right ventricle. VA would be looking at both the left ventricle and the right ventricle. But in both circumstances, it's important to use echo to assess for the position of the cannula. Also looking for organ recovery, so is the condition of the right ventricle getting better, and also looking for complications, which may be malposition of the cannulae, thrombus formation, pericardial effusion, or obstruction to the hepatic flow. So in summary, echo is very useful in the assessment of COVID patients. It can help to identify RV dilatation and dysfunction, but that may be multifactorial, so we just need to take all of those conditions into account. Pericardial effusions may lead to hemodynamic compromise, where patients can deteriorate very rapidly, and patients on ECMO should be scanned to identify possible complications and also recovery of the right ventricle. So thank you very much for listening. I'd just like to introduce the next speaker, Dr. Sagan Olusanya. He himself claims that he is quite possibly the UK's longest serving intensive care medicine trainee, which also suggests that he may have huge knowledge bank when it comes to our Q&A session at the end, which will come in handy. Sagan is currently working at St Bartholomew's Hospital here in London as a fellow, and he will be presenting the role of lung ultrasound in COVID. So I'll hand it over to you, Sagan.
Hello everyone, I'm just going to share my screen. It's lovely to be here. Thank you very much for the invite to talk to you all about the role of lung ultrasound in COVID-19. So I am biased in this case because I am actually a member of the Focused Ultrasound and Intensive Care Committee. And so therefore I have a big vested interest in using lung ultrasound in this outbreak. And that's really my main conflict of interest. I have a few others, but none of them are particularly relevant to this presentation. So what I'm here to talk to you about today is why do it, how to do it, what normal lung looks like, what abnormal lungs look like, and what kind of things you'd expect to see if you start scanning patients with COVID-19. So this slide is just something to remind you all as expert echocardiographers and sonographers that without realizing you've actually been doing lung ultrasound for years. The difference is I actively look at the lung, you try and avoid it. So in this situation here, you've got a parasternal long axis view, which shows lung coming in from the left-hand side of the screen. So you would avoid that, or you would call this an inadequate parasternal long axis view. I would say this is actually a pretty good view at looking at the lungs, and you can actually see the lungs there normal. So this is Daniel Lichtenstein. He's the person I call the patron saint of lung ultrasound. Back in the 80s and 90s, it was widely believed that ultrasound of the lung was completely useless because the lung was full of air. And as you know, air just scatters ultrasound beams. However, what Daniel Lichtenstein noted over years of painstaking research was that as lungs get sick and fill with different things, whether that's pus or fluid, you generate artifacts, particularly from the pleural line. And each of those artifacts actually tells you a story and gives you a signature that is related to a specific diagnosis. And he mapped all this out and published some seminal papers in the early 2000s that started the science of critical care lung ultrasound as we know today. And so these are the reasons why you do it. He worked this all out. He worked out that you can diagnose pretty much everything you can diagnose with a chest x-ray with lung ultrasound with a higher sensitivity and specificity. So overall, lung ultrasound's diagnostic accuracy approaches about 90%. And if you exclude ambiguous cases, in some case series, you can get nearly 100% confidence with final diagnosis of using CT or clinical or whatever you think. It can also be used for procedural assistance. So the British Thoracic Society, for instance, are very keen that any chest drain that goes in should go in under ultrasound guidance. It can reduce the amount of radiation you have to give to some patients. And I love it in ECMO patients in particular because you can get an answer at the bedside without necessarily needing to transfer the patient anywhere or hoist the patient for a chest x-ray. And in this time of COVID-19, saving PPE can be particularly important. And if doing a lung ultrasound at the bedside spares a radiographer having to come up in PPE and exposure to the patient, I think that's a great thing. So what probes can you use to perform lung ultrasound? The good thing is you can use pretty much any ultrasound probe that you have. We are all cardiac sonographers here, and so we're all familiar with the phase array echo probe. And the phase array probe actually turns out to be quite good for lung ultrasound. The FUSIC committee, however, do recommend that if you can get hold of a curvilinear probe, otherwise known as an abdominal ultrasound probe, that is the ideal probe that we think you should use for lung ultrasound, as it provides a really nice big field, and the refresh rate is ideal for looking at the pleura. So where should you put your probe? So there are multiple different, if you have a look at the literature, there are multiple different approaches that are described. For simplicity, the FUSIC committee recommend the 6-zone approach as pioneered by Daniel Lichtenstein himself. And these are all called the blue point, which blue stands for bedside lung ultrasound and emergency. And these points are all located, there's an upper one, a lower one, and a posterior one. And they're located just as you see in the picture here. So you can use your hands to find them. And they're roughly about 2 centimeters below the clavicle, the mid-axillary line for the upper point. The lower point usually tends to be right next to the nipple in pretty much everybody, along the line of the pectoralis major. And the posterior point is the most posterior and inferior point you can get of the lungs, just above the diaphragm on either side. So if you need to rotate the patient, you should do that. In terms of how to set up your probe, again, most of you guys are very familiar with an echo probe, and so that's a fine probe to use. I would adjust the depth to about 8 to 10 centimeters if you're scanning the anterior surface of the lung. And at the lung basis, you want to scan nice and deep so that you can see the diaphragm and ideally the thoracic spine and get an idea of effusions and consolidation. So you want that a bit deeper. Your gain should be bright enough to be able to display the pleural line, and I'll show you what that looks like in a second. You want your focal zone nice and high, and it should be just at the level of the pleural line. And the last one is a bit controversial. So ideally, because lung ultrasound is about understanding artifacts, you want all of the post-processing, so your tissue harmonic imaging, etc., you want that all taken off your image. However, some machines actually display better images with a little bit of post-processing left on. So what I'd actually recommend is you kind of play with the filters and things like that yourself and see what gives you your best image. And here are some images I'm going to show you. And this is a nice image of normal lung. And the big thing to understand is normal lung is boring. So just to give you an idea of orientation, so this is actually using a curvilinear probe. And with a curvilinear probe, you have the probe marker pointing towards the patient's head. With an echo probe, it varies depending on convention. I personally would prefer you having the probe marker pointing towards the patient's feet, as it gives you pictures that look the same as using a curvilinear probe and would tally with the radiology orientation. When you have the probe marker in the orientation that I've described, you'll end up with the patient's head on the left side of the screen and the patient's feet on the right side of the screen. And if you orient it in a vertical position, you'll end up looking through ribs. So on this screen, I don't know if you can see here, if you can see my pointer here, you can see this dark shadow on the left side here, and that's a rib. And there's another dark shadow on the right side here, and that's a second rib. And you want that orientation like that because you will be able to see a bunch of different structures at the top. So this is skin and subcutaneous tissue, but you will see a bright line that appears right between the ribs. And the first bright line, the brightest line that you see connecting two ribs is your pleural line. And that is your landmark for lung ultrasound. Once you've found your pleural line, you want to optimize your image just by tilting your probe very slightly. And you know the image is optimal because your pleural line will be as bright as it can be. And if your lung is normal, it looks kind of gray and homogeneous because there is basically the ultrasound machine can't pick up anything in here because it's all air. But what you will see is at regular intervals away from the pleural line, you'll see a horizontal artifact like that and like that. That is basically a reverberation artifact of the pleural line. And those are called A lines. One way of thinking of them is A lines for AOK lines. If you see A lines, it usually means your lung is normal. The last thing that normal lung does, so if you look very closely at the pleural line here, the pleural line moves very subtly back and forth, and it moves with inspiration, and that's called lung sliding. And all of those are features of normal lung. And now we come on to a little bit of pathology. So on the next few images, you'll have normal lung on the left as your reference, and a pathology on the right. So in this image, so here again, where my pointer is, you've got nice normal lung on the left. And if you look on the right side of the screen, you guys are probably used to seeing stuff like this based on doing lots of echocardiography. So here, this line here, this bright line here at the base there, that's the diaphragm. At the back here, there's a thoracic spine, and there's a big anechoic space here. That's a massive pleural effusion. This stuff swimming over here in the corner is actually just compressed lung that's being compressed by all the volume of fluid that's in there. So again, here you've got nice normal boring lung on the left, but on the right you can see lung here with all of these vertical beams kind of shining off the pleural line. These vertical beams are really, really important. So these are called B lines, and B lines are a sign of increased lung density of some kind or another. When you have, so normal lung has, or can have up to 2 lines in an interspace. If you have more than 2 lines in an interspace, that's abnormal. If you have more than 2 B lines in more than 2 interspaces in both sides of your lung, that counts as what's called interstitial syndrome. And that's the equivalent of bilateral opacities on a chest x-ray. If you've got interstitial syndrome, now the most common reason for you to have interstitial syndrome and have bilateral opacity on a chest x-ray is pulmonary edema. And so when Daniel Lichtenstein looked at this, 60 to 70% of the patients that he found that interstitial syndrome in had pulmonary edema. It does, however, show up in a number of other circumstances, in particular, an acute pneumonitis, such as what's caused by COVID-19. And so later on, I'll show you some COVID-specific imaging so you can compare the B lines here. This image actually shows B lines from pulmonary edema. So here on the left again, we've got nice boring normal lung with your A-line profile. But over here, this looks very dense. And you can see it almost looks like liver. this is the probe position here is actually at the upper part of a patient's lung. And what you've got here is dense tissue-like material all the way through the lung. So this is actually a very, very nasty consolidation. And so what happens as lung gets really dense and full of sputum, infection, etc., 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 it becomes consolidated, and some people use the word hepatized because it becomes like liver. So on autopsy, it actually looks like liver. On ultrasound, it also looks like liver. So this is actually what you're seeing here, a really big, dense, nasty consolidation. This is a slightly more subtle image here. So on the left here, you've got normal lung. On the right here, again, it looks like normal lung with A lines, but what you've got here is if you look at the pleural line here, the pleural line here is not moving. And over here on the left, if you look very closely, every now and again, you can see this little flash just kind of come in. So this is a very specific sign on lung ultrasound. This is what you see when you get a pneumothorax. So when you get a pneumothorax, your parietal and visceral pleura, which are normally intact and slide over each other, which gives you this gliding or sliding sign, they separate. And the sign that you see when they separate is that it stops sliding. If you look round the lung, provided the pneumothorax isn't a massive one, that completely takes away any sliding at all. If you look around the lung, you'll often find a point at which the normal pleura that slides meets the pleura that doesn't slide. That's the bit of lung that's still intact and tethered together. And that gives you this funny appearance of lung appearing in and out with respiration. And that's called the lung point. So this is a very specific sign and completely 100% specific for pneumothorax. So when Daniel Lichtenstein initially did all his research, he actually came up with a decision tree, which I'm showing you here. You don't need to remember this, and there's lots of research you can look up about it. And he called this the blue protocol. And this was his way of working through, bit by bit, which signs that he found on his lung ultrasound and working through that to get a diagnosis. The key thing here is, the reason why I'm showing you this is to recognize that the way lung ultrasound works is it's married in hand with history taking and clinical examination. So using a combination of those, you can get a really accurate diagnosis. And this is using the blue protocol, he was able to get a diagnosis with 90 to 100% accuracy. Now I'm going to talk about ultrasound specifically in COVID-19. And again, here it actually has multiple uses. It can be used to diagnose the disease. It can be used to risk stratify people based on how severe the images are. And some people are using it to triage people. Again, therapeutic and procedural guidance, people who have complications, and it's very useful, I find it very useful in the intensive care for identifying complications associated with mechanical ventilation. So these are going to be some images of patients with COVID-19. So on the left here, again here, that's normal lung. On the right, this is very similar to the earlier image I showed you of B-lines and interstitial syndrome. And you can see here that there's loads and loads of these vertical artifacts coming off the pleural line, and those are tons and tons of B-lines. The thing I would like to point out here, if you look really closely here, you can also see a horizontal artifact coming off the lung. That's an A-line. And I can tell you firsthand that when I was scanning this patient, if I tilted the probe very slightly, I would have seen an A-line profile, and it would have seen lung that looked just like that. And that is a very important thing to, those are very important things that you see in people with COVID-19. They have this B-line profile interstitial syndrome, but in between, in lots of areas, they have normal lung. And that is a sign of the significant heterogeneity of disease, and it actually matches up very closely with CT scan. There was a paper published yesterday, actually, that showed that the concordance between lung ultrasound and CT for people with COVID-19 was about 90%, with an area under the receiver curve for diagnostic accuracy of about 0.8, 0.9. So yes, this is a really nice demonstration, and so you'll see that when you scan these patients. The other thing that you'll notice if you look very closely, and this is one of the key things that helps you to differentiate the B lines you see in COVID-19 from the B lines you see in standard pulmonary edema, is the pleural line here. So if you look at the normal lung, pleural line and normal lung is just nice and thin. This pleural line actually looks irregular and just doesn't quite look normal at all. And if you look, it almost looks like there's little bites that somebody's taken out of it, so it looks a bit raggedy. And I'll show you an image. The next image will actually emphasize that even more. So again, normal lung here, and on the right, you've got even more dense B lines. So the B lines are dense to the point of nearly being contiguous. And you've got a whole bunch of little holes. These are actually called small consolidations or subpleural consolidations. And you can actually see that it looks like somebody's taken a little bite out of the pleura. And this is very, very classical COVID-19. And you see this is actually quite a severe area of COVID-19 disease. The other thing that you sometimes see in these COVID-19 patients, so this is a very recently described sign by an expert in lung ultrasound called Gio Volpicelli. Here you can see again, normal lung here, irregular pleura here, but you can see that there's a very thick beam here. This is a selection, this is a bunch of coalescent B lines. And Gio Volpicelli named this the light beam sign. And he described this in lots and lots of COVID-19 patients. And he, in his experience, described this as being virtually pathognomonic of COVID-19. Truth is, this is a feature that you would see in almost anybody with a viral pneumonitis. So it's not specific to COVID disease itself, but you will see a lot of these when you scan these patients. And the last thing you can also see in very severe disease is consolidation. So this is the same consolidation I showed you earlier, and this consolidation is actually from a COVID-19 patient with a very severe disease that required us to put them on ECMO to support. So the faculty of the Intensive Care Society and the Focused Ultrasound, the Focused Ultrasound group in intensive care have come up with a little diagnostic tool that you can use to scan COVID-19 patients if you're interested in lung ultrasound. And it kind of walks you through what to look for, what the abnormalities are, and makes some suggestions as to what you should actually suggest as your treatment. So lung ultrasound, I've made it sound amazing and wonderful, but it's not perfect. It is operator dependent. The better you get at it, the better your images will be and the better your diagnostic capacity will be. It's a surface imaging technique. So if your disease does not reach the pleura, you will not be able to see it. So some things, mediastinal masses, etc., you will not see on lung ultrasound. It's limited by the amount of surface you can get to the patient. So if the patient's got lots of dressings on, you're not going to be able to see. If the patient's got significant subcutaneous emphysema, you're not going to be able to see very much. And the biggest challenge we face at the moment with lung ultrasound is learning opportunities. There's a significant lack of mentors. However, there's lots of scope and there's lots of things that we're trying to do to sort that out. And that's the end of my talk. It's just to let you know that lung ultrasound can be very useful in critical care. It can be helpful on the wards as well in diagnosing and assessing patients with COVID-19. Here are a couple of references. At the top, we've got the Intensive Care Society has a page devoted to lung ultrasound and COVID-19. And some of my colleagues published a wonderful narrative review that kind of summarizes a lot of the evidence to date on COVID-19 and lung ultrasound. So I'm happy to answer questions after this, and please ask lots of questions via the chat. The person I'd like to introduce next is the next speaker, and that's Michael Purdon, who is a really experienced cardiac physiologist. He's been a cardiac physiologist for almost as long as I've been an intensive care registrar, and he works in Cambridgeshire and is a BSc representative and helps with the exam. So over to you, Michael.
Thank you very much, Sagan. What a really interesting talk. I have to say, locally, our physiologist group have been really interested from the beginning of COVID in the idea that we should be able to learn basic lung ultrasound and support our ITU department. And it was all a bit too late to do that right now. But that's definitely something we'd be interested to do in the future. So let me see if I can share my screen. Okay, I'm hoping you can see that. So we're all now looking for ways in which to tentatively reintroduce our non-COVID diagnostic clinical activity as we kind of pass through the peak of this pandemic phase. But we need to remain conservative in our approach and consider how best to support our patients and services whilst minimising risk to staff and patients alike. COVID-19 is going to remain with us, and the probability of a second wave later in the year means it will not be possible to return to our previous working models, and we need to learn to adapt. The models and ideas I'm suggesting are clearly based on the needs and facilities local to us and our department, and obviously providers will need to adapt to their own circumstances. So there's a problem to be solved here. We've all got many hundreds of patients who've had appointments booked in April, May, all deferred until further notice. We've got more referrals coming in, although a significantly reduced rate than normal, which means that there's this unknown potential out there, and we don't really know what the diagnostic surge will be and when it will come, and we just can't open up as normal. So the first steps for us have been to risk assess the booked or planned patients. I'll just give here an example of our scientist-led valve service. This is split into two cohorts, the simple surveillance group with mild valve disease at the last visit, or who have had previous corrective valve surgery. These patients already booked in, had their previous echoes reviewed, and where this showed reasonable stability, their appointments were deferred for a period of up to X number of months. Patients with the more significant valve lesions all received a telephone consultation from the physiologist, going through a questionnaire with patient-reported outcome measures style. This allowed us to either defer the echo with the patient's consent, or to reassure them that their echo would be among our high priority group once circumstances allowed us to go for some kind of restart. And a key factor there is to be able to document all these things and get it into patient notes somehow, that there has been some communication with patients. So we need to spread these patients out. Having triaged our referrals, we now have this non-urgent but high priority group to bring into green or clean sites considered at lower risk. We're very fortunate in that one of our acute hospital departments is located in a building remote from the main wards and ED, giving us this as a green facility with high-end machines and 3D imaging for the more complex cases. And over the past few weeks, we've been working closely with our primary care colleagues to build on existing community-based echo services with additional sites post-COVID. During this immediate initial phase, starting next week, we're limiting this to community hospitals and non-GP facilities, as they're not open yet, GP world. So this is one way to spread the patients out and reduce contact. Additional considerations are opening facilities for longer each day. So our normal working day is 8 till 6, but we're looking at 8 till 8. And increasing outpatients over the weekends as well. Okay, so this is our kind of appointment pathway. Our admin team are calling the patients, probably as I speak, to agree an appointment time and location, and ensuring that the patient is willing and able to attend, and going through a screening questionnaire, which I'll just briefly put up in a second. Then the day before the appointment, we call the patients again to ensure there's been no change. So we are minimising the risk as much as possible. We'll also take this opportunity to ask the patient, if possible, to bring a record of their height and weight. And then when the patient arrives to the designated area, if possible, we'll meet them at the door, check their temperature. If it's greater than 37.8, then send that patient away, defer, give advice. If normal, then we provide the patient with a fluid-resistant surgical mask and alcohol hand gel, and the physiologist, of course, is in appropriate PPE at this point already. Then complete the scan as required. So it really might be prudent to pre-plan based on the patients that you've got coming. So you might need to do a full data set on a first attendance patient, but if this is a follow-up of some sort, then you may well be able to really focus your echo to minimise the contact time. Another way of minimising contact time is completing on measurements offline afterwards. Now, in our trust, we already advocated a 60-minute slot for echo, scanning and reporting pre-COVID, adding in just another 5 minutes at the moment to allow for donning and doffing of your PPE, plus some clean down time. And for our off-site clinics, we're taking 2 physiologists with a VidIQ echo machine and a high-spec laptop with echo pack on it. So the physiologists are swapping over, and the patient attendances are 35 minutes apart to try and make best use of time. This is just the questionnaire that we are using, and our admin team are happy enough to go through these. Okay, so complex echo has been mentioned a little bit already. TOE is unavoidably an aerosol generating procedure, as we know, and requires full level of PPE. But we need to risk assess each case. how will TOE alter management in the current circumstances? Are there alternative diagnostic modalities at your disposal? So, you know, let's plan this as a wider team. And then where do you perform your TOE? Can you do this in an area with high frequency air change to avoid dead time? I'll go into this a little bit more in a second. Stress echo, similar considerations really. Both DSE and ESE are potential AGPs, so let's assume the worst. If a stress echo, is a stress echo the only available test, and will it really, you know, change outcome at the moment? Now, timing of things and room ventilation. ARTP have recently provided valuable guidance to respiratory investigations departments, which is all really pertinent to us for these potential AGP diagnostics. So the room will need to be vented after the patient has left the room, and the length of time venting the room will depend on the number of air changes in that room per hour. Now, a single air change is estimated to remove 63% of airborne contaminants, and then similarly for each subsequent air change. So after 5 air changes, there's less than 1% of the original airborne contamination thought to remain. So this is where you've got your aerosol-rich environment, and we're reducing that right down to less than 1% of the original. So, you know, following this period, you can go back in, clean down, and prepare for the next patient. Our rooms in the trust, in the normal clinical rooms, have been confirmed as a minimum of 6 air changes per hour. So this is then the process that we have for carrying out in between patients, taking up to around about an hour and a quarter in a standard clinical room. We're looking to see if we can do TOE in a theatre or endoscopy suite environment in our buildings. I know that both of these have 15 air changes per hour, reducing your 50-minute wait time down to 20 minutes before re-entry and cleaning, which clearly makes a significant difference. Now, just some work we very quickly carried out at the beginning of this pandemic was to try and support the most effective clinical areas with access to some form of echo at all times. Our sites are not huge, and we do not have large bodies of cardiology registrars or physiologists able to perform echo out of hours. So we wanted to put something in place to support ED and ICU at the beginning of this pandemic period. So we rolled out some basic image acquisition training to as high a volume as we could of ED and ICU staff at both hospitals. And where possible, we enabled connectivity of their existing ultrasound equipment to our storage and reporting systems. And we've procured some additional handheld echo devices capable of image storage and Wi-Fi transfer to our department for review. So we aim to continue this and consolidate on it as the months go on, to allow a safe early access to echo model where clinicians can take the images and we can review them remotely for reporting and advice. And we have a couple of laptops set up to enable us to do this from home even. That's just a snapshot of the training material we put together, and similarly that's just a record of basic training for those taking part. Okay, something other than echo. I'm not even going to talk about exercise ECG. Lab work, it's all potential aerosol generating, so let's, you know, I'm sure everyone's treating that with caution, and please consider the room ventilation guidance that I've just talked about. Hopefully, you know, all elective cases and non-urgent inpatient cases in the months to come will have been pre-screened for COVID-19, and I think that's going to be true for the TOEs as well, hopefully. Okay, so device follow-up clinics tend to involve high volumes of patients in packed waiting areas, so that's got to change. Our invasive physiologists have done a fantastic job in triaging the pacing and devices cohort. They too have introduced telephone consultations, and this will continue and will enable reduced frequency of follow-up where the battery life is long and the patient is well. And we can utilise facilities for remote monitoring wherever possible, and in the same vein as echo, we plan to spread out the clinics across sites and days to reduce the volume coming through a clinic and a waiting area. I'm sure many departments are coming up with great ideas, The most novel I've heard of so far is a department providing drive-through pacing checks and ambulatory ECG from a porter cabin in their car park, which I think is just genius. On ambulatory monitoring, we're also developing a palpitations pathway for ED and ambulatory care to enable us to send palpitations patients home from ED with, in our case, an alive core cardio device with an app on their phone and a palpitations email address, so they can go home, take ECGs on a regular basis and send them to us for review. I think they're going to have this for 6 weeks before returning it and then having a telephone consultation with either an arrhythmia nurse or a physiologist. That will reduce the number of patients we've got coming through for tapes. In the interim, we've been delivering ambulatory ECG devices with electrodes attached and running to the patient's doorsteps, providing them with written instructions and telephone number for queries. And of the first 50 devices we sent out, there's only one came back unreadable, and the rest were of diagnostic quality. So I think we'll probably keep this up and running in some form, possibly to support care homes in particular. So moving forward, we're planning to work with primary care and commissioners to set up a joint service where we're supporting primary care who will fit and manage the tapes in their area. Well, we provide and then upload digitally to us, to our server, and we provide a report with physiologist delivered advice and guidance, including kind of a range of pathways agreed and supported by our consultant cardiology body. So thank you very much for listening. Let me just take the opportunity to thank my team at Peterborough and Hinchley Hospitals for all their hard work now and as we progress, and to the respiratory investigations team for their detailed research and planning around managing AGPs, which I've been lucky to borrow. So let me hand you over now and introduce Dr. Dave Oxborough, who I think is going to talk to us about the recent BSc COVID-19 survey. I'm sure many of you will know Dave. He's a reader in cardiovascular physiology at Liverpool John Moores University. Thank you.
Screen. Okay. Okay, and hopefully you'll see this. Okay, I'm going to spend the next 10 minutes presenting some of our preliminary findings from the BSc COVID survey. We've all been thrown into this unprecedented situation, and we have to adapt and change and evolve in many ways, and our clinical practice is no exception. This survey was open for approximately 3 weeks, and it allowed us to gauge a snapshot of echo service delivery across the UK and Ireland during the early stages of this pandemic. So the primary aim of the survey was to establish the national picture of services in order to generate valuable information that would allow us to plan for the next stage of the pandemic or for future waves. This general overarching aim led to more specific questions related to what changes to service delivery were implemented, what was the incidence of COVID-related illness and isolation in echocardiographers, what PPE was available and how was it used, what echocardiographic protocols were employed, including the equipment, and then finally we employed a service evaluation to the departments, which allowed us to establish what was learnt from the experience, what challenges were encountered, and how individuals and departments might plan for the next stage. So we had 32 questions, around 130 responses once we excluded all duplications. The distribution of centres was good, and if you look at the map here, we can see that most of the UK is represented. It's quite important when considering the variable infection rates and service demands across different regions of the UK. The main service providers were from secondary care, closely followed by tertiary care, and primary care and community clinics were also represented, but on a smaller scale. So the initial question was related to service changes and what was implemented. And if you look at the word cloud, you can see that the larger fonts represent more frequently answered words, and It's apparent that changes related to staff, to work patterns, cancellation of clinics, introduction of hot and cold teams and equipment, and also the impact on inpatient provision were also extremely relevant and dominant. But more specifically, routine lists were cancelled at a time that generally coincided with lockdown. However, a small minority of departments did keep their lists going. Referrals were triaged, and those scans that were considered urgent were usually and generally undertaken. Inpatients tended to be scanned on wards, and there was a significant change to working patterns, and this included the use of 7-day weeks, extended hours, introduction of on-call, and trainee lists again generally were cancelled. With regards to workload, departments reported redistribution of work to ensure ample resources were available for dealing with these patients of the pandemic, whilst dedicated equipment, areas and teams were made available. To this end, 40% of departments purchased new equipment, which was generally handheld ultrasound for focus scans. In addition, for thinking about risk assessment and risk of infection, this was minimised by changing the department through throughput, thinking about the layout of waiting areas, ensuring adequate social distancing. And PPE equipment was made available, and I'll address that on the subsequent slides. But it was a national and local policy was adhered to and noted. So let's think a little bit about the service change now and absolute echo provision. Well, overall scans per week were significantly reduced compared to standard service, and this reduced to less than 80 in tertiary centres to less than 50 in secondary care. Tertiary centres would be performing similar numbers of confirmed COVID and suspected COVID and non-COVID outpatients, whilst secondary care performed more outpatient scans and less COVID scans. Inpatient numbers here are probably driven by the hospital size. So with regards to staff illness, 67% of departments reported that they provided COVID testing for staff, and that resulted in 1.6% of all of echocardiographers, that's from a pot of 1,500, being positive for COVID. Add to this 11.1% who had to self-isolate due to symptoms, 7.2% due to household illness, and 4% had to self-isolate for underlying medical conditions. I think overall, there was a 22% reduction in workforce, or they were unavailable at some point during the early stages of this pandemic, and that's really quite important to note. So the actual scans were predominantly focused. If we look at this chart here, for those patients with confirmed COVID, it was primarily focused, and those who suspected it was still predominantly focused, but to a lesser degree. And this was the use primarily of handheld devices. In addition, 90% of images from confirmed COVID patients were archived, and a full report as per local policy was generated in 82% of cases. And the dedicated machines were used in the majority of cases for those with confirmed COVID. This is a slightly more worrying slide. There was a general, this is PPE information and what PPE was available and utilised for confirmed COVID and suspected COVID. There was a general variability, a lack of standardisation of PPE, irrespective of the existence of professional guidelines. And I know we have this gloves here at 88%, but when you go further into the survey, in the other section, it was highlighted. So glove use, thankfully, was 100%, but still, in many cases, there was insufficient PPE availability. In those departments that didn't have sufficient PPE, from this survey, there was no obvious trend to increase staff infection or isolation, but this is a survey and it's quite difficult to pull that information from this type of research. So what were the challenges that were observed? And again, this word cloud highlights some of that. Keeping fit testing for staff up to date, having sufficient PPE was frequently reported. Others and other departments highlighted the conflicting information from professional bodies and guidelines, as well as the challenges associated with the rotation of staff. And in some cases, a resistance to change, which is quite normal. The difficulties associated with ensuring to social distance and distancing for patients and staff was also frequently reported as a real challenge. So what did individuals learn? What did departments learn from this? Well, there's some important statements that were common threads, and I've highlighted some of these here. Crucially important, and this is absolutely fundamental, is that staff were described across the board as being amazing and flexible and will pull together in difficult and challenging times. It is clear that people worked over and above what was expected, and overtly clear in communication and teamwork are absolute key. The importance of adapting working patterns related to infection, time and resources was again highlighted as extremely important and something they learned. The most frequent response here regarding being more stringent on triaging of inpatient referrals, because it was clear that actually many of these inpatients that we do on a day-to-day basis were actually not necessary or required just a focused scan. And equally, it was clear and similar to what Bushra was saying in the earlier presentation, that scans should only be performed where they may cause a change in patient management, particularly in those with a high risk of infection. Learned that there was a clear learning curve based on the use of handheld scanners, their application, and also thinking along the lines of how we can archive and report, and also trying to make them more dedicated to the patients with confirmed and suspected COVID. And finally, it pops up every time. This is to ensure an appropriate and available PPE. So we've got to think about what the key information we obtained from the survey, but also thinking about looking forward and considering the potential of another wave of this virus or something similar. So I think we have to go that this is the new normal. And I think we have to prepare early. Consider evaluating how to maintain social distance. Think about the allocation of space, the space around a patient, the space you have in a department. Direction of patient flow, asking patients to not come early, staggering lists, increasing scanning time, and dedicated equipment. Now, this can be implemented now and can continue in the days when infection rates are low and diseases are absent. But alternatively, systems should follow standard operating procedures, and they can be and should be easily interchangeable when alert levels are raised. I think in this regard, it's crucial that professional bodies such as the BSE provide clear and consistent guidelines. That will happen. We are evolving and learning during these times, and therefore recommendations will also evolve in tandem with scientific evidence. I think the use of surveys such as this one will help to collect and audit service provision, allow us to adapt and change in a dynamic manner, and that's what's happening. It's a continual evolution and development, and we have to respond as and when. We should ensure that sufficient PPE is available and that it is appropriate for the clinical scenario. This will be the new normal, I don't doubt, and will be ongoing throughout the pandemic and beyond. Much of this planning should allow us to reduce the impact on other services. If you look back at the previous slide, we are certainly doing fewer echocardiograms than we have done normally. So there are resources and staff available, and if efficiency can be maximised through careful planning, then we should be able to maintain some services and additional work. That aside, remember that up to 25% of the workforce in this 7-week period were ill or isolating at some point during that time. And I think staff testing for COVID should help with this. And finally, I think it's important to remember that the ECHO staff are amazing, and therefore it is imperative to maintain morale and be supportive. Thank you. Okay. Can we go back to Kelly and Richard?
Dave, thank you very much.
Thank you.
So we're going to have a very short question and answer session now. We had a lot of fantastic talks. They, as they tend to, have run a little on beyond what we were hoping to run to. So we're going to have a few quick questions and we're going to try and answer some of them. Before we go into any of the questions, the one I'm going to address first is one that's been asked. It probably fills about 50% of the Q&As that we've had, and that's regarding PPE. And I know Dave's just spoken about it, so I might ask Dave to contribute as well. The question of PPE keeps coming up. It keeps coming up in the Echo lab, but it keeps coming out throughout the entire hospital and outside the hospital as well. And it does cause a huge amount of concern for us as healthcare professionals, as well as the general public and our patients. So I'm going to have a slightly vague answer to some of the questions taken together. So first of all, there is no universally accepted answer to this question. There is no definitive answer that what PPE must and must not be worn at different times. So we haven't got perfect evidence that tells us what we must be doing for certain. The risks are probably going to be different under different situations. So the risk will be posed by both the patient and how contagious they're likely to be, as well as the procedure that the patient's undergoing. And so therefore those factors will influence the guidance that is issued. The BSE guidance has been deliberately designed to be in line with the advice from the European Association of Cardiovascular Imaging and to be in line with the European Centre for Disease Control's guidance. So we are mirroring their guidance, and that's who we're following rather than following the NHSE guidance. There was a paper published in the Journal of the Royal College of Physicians very recently, which looked into the concerns that healthcare professionals have about PPE and its adequacy, and their conclusion was that probably that there are grounds for staff to have concerns about PPE and its availability and the guidance that we're getting, and that the NHSE guidance needs to be reviewed in light of those concerns and potentially revised. So we don't have a perfect answer, we don't have perfect evidence to provide a perfect answer, but our guidance is going to be in line with other professional bodies, and that's why we have chosen the guidance that we have. Dave, is there anything that you wanted to comment, or any of the other panelists, about that?
I agree fully, Richard. I mean, with regards to the survey, it was clear that departments were very concerned about the lack of standardization, often the inability for professional guidelines to be directive and prescriptive about what is required, and that's because the scientific evidence isn't fully there. I think by doing things like this, by ensuring that we do these surveys, auditing, developing the scientific evidence base, I think we will have better information, and I think in due course the guidelines will be more robust and clear.
Yeah, absolutely. I don't know, but I suspect as well that hopefully now that I think the pandemic caught us a little off guard, and hopefully we'll be able to increase production and there'll be more available PPE in the future as well. Another thing that we may have to do, and this may be addressed in the BSE's framework that got put on the website today, is again, think about the way in which we can alter our practices to conserve PPE. So we might have, say, 2 sessions a day where you go in, you don your PPE for scanning patients who are COVID positive or COVID suspected, and then you wouldn't necessarily come in and out of your outpatient room to go and get a cup of tea. You might have your refreshment break, go in, do all your scanning in one go, and then come out. So sort of measures that we can do in order to conserve the supply, because obviously anything that we conserve will be available for us later on. Okay, so we're going to touch on PPE. We've obviously touched on PPE. There were a lot of questions about it. I think some of the answers are going to be put up on the website along with the recording of this webinar. So please go to there if you want to read those answers that have been typed already by some of the other speakers. Okay, so Kelly and I were sort of making a note of some of the questions as they were coming through. Kelly, were there any questions that sort of caught your eye that you thought we could discuss as a group?
So I thought one which I found quite interesting, and I'm not sure if Mikkel or Dave, you have a response for this one, but it was just related to the use of our level 1 screening echo, and how we're going to use that post-COVID. So whether or not actually our practice changes to reduce the burden on centres in the long term, and whether we actually use it as a way of triaging who needs a full scan in the future. Whether you just had any thoughts on that?
Yeah, so we're not a massive centre, so as I said, we don't have you know, a plethora of cardiology registrars able to sort of provide this, you know, sort of early access inpatient echo and this kind of thing. So you know, so we've gone down a slightly different route of looking to train clinicians in acute areas to be able just to take pictures to start with, that we can then review remotely. Now, we have also talked about the idea of a very focused echo, so level 1 type thing, and focused specific to follow up. You know, that's definitely a question that needs to have a bit more thought, and a lot of people have their own answers to this, but I think we will be including something along those lines for sure. And the other factor, as you know, as we know, echo has often been seen as fairly low-hanging fruit for clinicians, whether it's in primary care, secondary care, inpatients or outpatients. It's pretty easy to ask for an echo. So I think the thing that we need to be stronger and firmer on is really getting to the crux of whether the echo is needed at all, at any level. Do you actually even need to put a probe on? Could you just work this out? So you know, so there's really various points of looking at that.
And Michael, that's exactly what came out of the survey. Again, was the potential referrals for inpatients that were not necessary.
Yeah. And
maybe focus scans will help triage that and free up the resources for more urgent things.
Absolutely.
Okay, so looking through, again, one of the questions, this may be for Kelly, there was a question about assessing the right ventricle, and they said, should we just rely only on visual assessment, or is there anything else we should be doing beyond that, even if we're doing a focus scan?
Well, it's a difficult one to answer. I think we really need to weigh up the risk of performing a more comprehensive scan, where we do perform quantitative measures, so TAPSE and also tissue Doppler of the RV free wall, against the risk of added time and exposure to the disease. So I think that's a difficult one to answer. Perhaps it depends a little bit on the risk, whether the patient's confirmed COVID, whether they've had a baseline scan in the past, whether it's a borderline case. So if it's a severely dilated left ventricle with no contractility, we know it's severe. And having TAPSE or tissue Doppler may not make that much change. We can do retrospective fractional area change, which might be useful. That can be done retrospectively away from the patient, so it kind of offers a little bit best of both worlds in terms of exposure, safety, and also providing a quantitative measure.
Yeah, that's certainly something we're saying, is that any measurements, if they can be done away from the bed space, do them offline later on. Yeah,
agreed.
And I think that, sorry, Johnny.
Sorry, not in the most ideal scenario as an echo purist, but you can actually perform TAPSE retrospectively as well.
Mm.
I was going to say that TAPSE and also strain to a point. Of course, you've got to think about the technical limitations and the quality of the images, but anything you can do post-processing is going to help.
Yeah, yeah, absolutely. A question about swabbing patients came up. Is there any role for swabbing patients prior to them coming in for scans? I can see some practical drawbacks of that. I don't know if that's anything that ever got considered. I think the time frame would maybe make that a little bit too difficult. The results would take many hours to get back. I guess that wasn't something we were thinking that we were doing. There's a question about vegetations. Are we seeing any COVID vegetations on valves? Is that anyone seen anything that I haven't, and I haven't seen it reported?
it's difficult to say in the population that we have. We are going to have an incidence of infective endocarditis, but we would normally have that. I don't know that I've seen an increase in the number of infective endocarditis cases within the COVID population.
Yeah, I think that's really important. A really important point to make is that the majority of the disease that you will see in your patients who are COVID positive will be either pre-existing or maybe unrelated to this disease. So we will still see valvular dysfunction. We will still see, you know, the full spectrum of cardiovascular disease that we normally see on echo in these patients, particularly because they are the sorts of patients who are likely to be at risk of cardiovascular disease. And whilst we're looking for the weird and wonderful, it's, you know, we shouldn't sort of forget that we should be looking for all of these other conditions that patients might normally expect to have.
Yeah, absolutely. Perhaps a slightly more clinical question for the clinician. So for a patient who's on warfarin, will they be protected from hypercoagulation as a complication for COVID?
Okay, so from what I've read so far, there's not enough evidence to answer that question just definitively. What we are saying is that in our trust we found that INRs, which are used to measure the efficacy of the anticoagulation, have become quite difficult to maintain in the sicker patients with this disease. So in hospitalized patients who are on warfarin, we are recommending they are switched from warfarin to subcutaneous heparin for the duration of their hospital admission. But that's only for hospitalized patients, that's not the outpatients. I don't think we can say that warfarin protects you from microthrombosis. I don't think we really fully understand the incidence of microthrombosis and how much of a player it is yet. Okay. Guys, if there's no more questions, I think we've overrun quite a lot. We're probably going to wrap the webinar up now. So I'd like to just quickly make a few closing comments. So first of all, any questions which we haven't answered this afternoon, we will answer them, and we will put the question and the answer up on the website along with the recording of this webinar. If you've got any thoughts you'd like to share on Twitter, there is a Twitter hashtag that you can use, and that is hashtag BSE, I should have guessed that, BSE RSM COVID. Okay, that's hashtag BSE RSM COVID. The BSE have put a framework of guidance with respect to how you're going to get your services up and running again after the peak, and how you're going to do that in a way that maintains both patient and staff safety. And that framework is available on the BSE website from today, so go and have a look at that. There are CPD points available. There's for clinicians, there are Royal College of Physicians CPD points available, and there are BSE CPD points available, and you have to complete your survey if you want to get those. So as the webinar ends, you'll get a link that you can go to in order to complete that and get your CPD points. Don't worry if you don't follow that link or you don't have time to do that now, because it will be emailed out to everybody who pre-registered in the next 48 hours. If you're re-accrediting, then you need to submit your certificate of attendance when you go to re-accredit. I'd like to finish by saying thank you to the Royal Society of Medicine and to the British Society of Echocardiography for hosting this webinar. I'd like to say thank you to GE Healthcare, who've provided funds to allow us to host this today. I'd like to thank all the speakers who've given up their time and efforts to prepare their talks and to answer your questions. I'd like to thank everybody who logged in today, the entire audience, and especially those of you who submitted questions to us that we'll try and answer for you. Thank you very much, everybody. We hope this was useful, and we hope to see you at our next webinar. Thanks.
Thank you. Bye.